Thank you, Dr. Balika. And we are going to move to our next speaker, who is none other than Dr. Sitalakshmi. Very happy to introduce you today. Actually, one of your webinars that you conducted was a trigger for Sunil to think of this webinar. He had shared that with us. A beloved teacher of many of us who have been at St. John's since the 1990s. You have been a lifelong Johnite after you completed your post-graduation at St. John's and stayed there and now serve as the professor and head of Department of Transfusion Medicine and Immunohematology. She is also involved in medical student education and curriculum, as well as faculty mentoring. Welcome to this talk.
Greetings from St. John's. Glad to be a part of this program. Thank you, Maya. The previous speakers have set the stage for me. I'm going to be briefly discussing the key prognostic biomarkers in COVID-19. Next slide, please. So during the early weeks of the COVID pandemic, one of the thoughts that struck my mind was, what is the role of a laboratorian? Is it limited to diagnosis and epidemiological surveillance, or do we have any role in terms of prognostication and therapeutic monitoring of the disease? Next slide, please. That led me to drawing your attention to two important components, which has already been discussed by the previous speakers, the viral factors and the host immune system. An interplay of these two important components contributes to who are the ones who are likely to be infected, what is the duration of the disease, what is the severity, and what are the chances of reinfection. Next slide, please. So, are there biomarkers that could play the role of prognostic indicators, like in any other disease, to enable risk stratification, guide interventional studies to target patients who are at an enhanced risk of severe disease, thereby help us to optimize allocation of limited human and technical resources during the pandemic, and also improve clinical management? Next slide, please. So if we look at our laboratory armamentarium, there are several of them. Some of them were well discussed by the previous speakers. We have several hematological parameters, biochemical parameters like troponin that was discussed, immunological parameters, and hemostatic parameters, which could play the role of prognostic indicators. Next slide, please. So if we look at the trend of these indicators over the course of infection, which could broadly be classified clinically into three phases: the viremic phase, the pneumonia phase, and the severe phase of the disease. It's well documented that the T cells gradually decline as the course of the disease progresses. At the same time, the inflammatory markers and the hemostatic parameters like D-dimer gradually increase with increasing severity of the infection. Next slide, please. So one of the parameters that has been well studied and documented in literature is a simple monitoring of lymphocyte count. So the authors of this particular study, who looked at lymphocyte count between the two groups, the survivors and non-survivors of COVID-19 infection, proposed what is called the time lymphocyte percentage module. So they assessed the lymphocyte count at 2 time points. The first time point was 10 to 12 days after the symptom onset, and the second time point was about 17 to 19 days after the symptom onset. They assessed the lymphocyte percentage and evolved a cutoff. It was observed that those who had a lymphocyte percentage of less than 20 had a more severe disease, and those who had a greater than 20% infection sailed through the infection and were on their road to recovery. Next slide, please. So those who had a lymphocyte percentage of less than 5% were critically ill, and mortality rate was documented to be very high. Those who were having a lymphocyte percentage of 5 to 20% had a severe form of disease required ICU monitoring, and those of them who had greater than 20%, both at the first and the second time point, recovered from the disease without any complication. Next slide, please. It was also proven that this kind of classification based on lymphocyte count correlated well with the clinical classification of the disease into moderate, severe, and critically ill groups, thereby highlighting the prognostic significance of just monitoring a lymphocyte count over a period of time. Next slide, please. So if we look at the peripheral smear of these patients, in addition to lymphopenia, there were presence of reactive lymphocytes, and the hematology analyzers that are available in today's market give us several parameters. One such parameter is the presence of high fluorescent lymphocytes, which is well depicted in this so-called scattergram. Now, besides this, the CBC parameters can help us derive several other formulae-based data, which can be used as prognostic markers in the progression to predict progression of COVID-19 infection. Next slide, please. Moving on to another important area which was discussed in the previous session. One is the COVID-associated coagulopathy or the hemostatic markers. Now, lung being the epicenter of this phenomenon of so-called pulmonary intravascular coagulation is associated with coagulation activation, dysregulated thrombin generation, and impaired natural anticoagulant and fibrinolysis, contributing to both arterial and venous thrombotic events. Cases with association of antiphospholipid antibody has been well documented in literature. Severe COVID-19 reflects a confluence of vascular dysfunction, dysregulated immune function, and both contributing to the occurrence of thrombosis. Next slide, please. So if we look into the pathology of thrombosis in a little greater detail, as well illustrated in the previous talk, the local and systemic inflammatory response contribute to hypercoagulability with an imbalance of procoagulant and anticoagulant mechanisms, high levels of ultra-large von Willebrand factor multimers, high factor VIII and tissue factor, results in increased thrombin generation and a high level of D-dimer production. This, in association with the endotheliopathy well described, enhances the procoagulant phenotype, resulting in both micro and macro thrombosis. The microangiopathy associated with microthrombosis contributes to the multi-organ failure and ARDS-like picture, and the macrothrombosis results in the so-called thromboembolic events. Next slide, please. So the systemic inflammatory response and the interplay with coagulation, activation, and thrombin generation is mediated by several mechanisms, some of which are the polyphosphate derived from the microorganisms, the neutrophil extracellular traps. Both of them enhance the procoagulant response of the intrinsic coagulation pathway. Besides this, the endothelial activation, which is due to the pathogen-associated molecular mechanisms, as well as the cytokine response, all of them enhance the prothrombotic mechanism, resulting in the so-called immunothrombosis. Next slide, please. So the Virchow's triad represents a fundamental construct, which is described by the abnormal endothelial surface, the altered blood flow, the procoagulant mechanism products in the circulation, all of them enhancing the tendency to thrombose in an individual, which is one of the complications in severe COVID-19 infection. Next slide, please. So having known that thrombosis is an important complication of COVID-19, could we use D-dimer as an independent prognostic biomarker? So D-dimer, we all know, originates from the lysis of cross-linked fibrin, and rising levels indicate activation of coagulation and fibrinolysis. D-dimer is said to be elevated in up to 70% of patients with COVID-19 infection. D-dimer elevation upon admission was associated with increased disease severity as well as inpatient hospital mortality. Significant correlation between D-dimer levels and severity is based on clinical staging is well documented in the literature, and D-dimer levels greater than 1 microgram per liter is the strongest independent prognostic marker that has been described so far. Next slide, please. So having discussed the hematological and hemostatic markers of the disease, I move on to immunological biomarkers. Low CD3 and CD8 levels of T cells, high cytokine levels, presence of tumor necrosis factor alpha, and suppressed interferon gamma production, all of them could be used as potential immunological markers because of their correlation with disease severity. Next slide, please. So besides being used, the laboratory parameters being used just for diagnosis, the biomarkers could play an important part in monitoring the patient. Laboratory abnormalities are present at diagnosis. Patients presenting with severe disease seem to have more significant laboratory aberrations. Identification of potential lab risk factors can help predict progression of the disease and severity. Early and timely monitoring of these predictive indicators are known to enhance care and improve prognosis. Next slide, please. So I come back with the question that I started. Does laboratory have a role to play? And with the little literature that we have and with the data that we already have, maybe we are trying to answer this question. Can laboratory tests be utilized as key prognostic biomarkers to assess disease severity and predict risk of disease progression? So with this, I conclude this presentation and I'm open to any questions. Thank you.
Hi, Dr. Sitalakshmi. Wonderful presentation. Thank you. Thank you for joining us. I have a question. You know, there are a lot of COVID patients who remain positive even after they have complete clinical recovery. Can you comment on that? And how is John's monitoring if you have any such patients?
Yeah. So what you said is very true, that the RT-PCR test detects the viral RNA. So the presence of RNA does not always mean that the virus is still surviving. So just it detects the RNA, which can remain for long after the patient recovers. Therefore, the ICMR protocols come into picture back home in India. We have the ICMR protocol, which talks about monitoring a patient who is recovering from COVID-19 and demonstration of 2 RT-PCR negative tests at least 24 hours apart is required for us to declare him non-infective. And there is enough literature to show that even up to 28 days post-infection, this viral RNA could still be there in the samples. So it's important to test and show 2 RT-PCR negative results before we declare that individual safe.
Thank you so much.